Welcome back to Season 2, Episode 2 of Ausjdocs. Today we are joined by Hash from Episode 1 and Ajay, who is an advanced trainee in oncology. He has some pearls of wisdom to share with us today, so let's start the show. All right. Hey guys, welcome to our podcast. So this is our second episode for season 2, isn't it? So we're going well at the moment. We are welcomed by Hash, who was in the first episode, and he's coming back, and also AJ, our new guest here. Welcome, guys.
Hello.
Thank you for having me again. If we can release one episode every fortnight, I think that'll be a record.
Yeah, that'll be amazing. And I don't know, you saw Hash, but your episode's going crazy at the moment, which is a good sign.
I think it's
as
because he's
always.
so humble.
Yeah.
He's so humble. He wouldn't have acknowledged it.
Look, I think there
Yeah,
was
it's,
was a comment about that actually.
Yeah,
They
I saw
loved you.
that.
Yeah, did you?
Yeah, I saw that,
yes,
and I was
they
like,
made a lot of fun out of me because of that.
yeah.
So now, because we record on free Zoom, so we're pretty time limited here. So let's just get into it, hey?
Yeah, let's get it on.
All right.
Yep.
So this is AJ. AJ is a friend of mine, and we went through med school together, and then we did internship together. Our first job and our first rotation was together, actually. And then he decided he wanted to do BPT and oncology. And looking back at your podcast episodes, you didn't have. I mean, you had a little bit about BPT.
Yeah, but we didn't have
but
the
not
whole
a great
episode for
deal.
it. True.
You didn't have the whole episode, and you don't have anything on oncology. And I can
Mm.
see you made a post about oncology. So AJ is going to share his experience because I think there's enough evidence to suggest that there are people out there that want to know. And certainly when I think about when I was a medical student or a internal resident, it would have been nice to have this kind of resource available. So without further ado, this is AJ. AJ, tell us in 30 seconds what you're doing with your life right now.
Well, what I'm doing with my life right now is I'm
You're unemployed. He's unemployed.
Which is a great starter for somebody to to give people advice at the moment. No, so
give us career advice.
Yeah.
What happened, AJ? Why are you unemployed at the moment?
Well, all the mistakes just caught up to me. No, I'm just kidding.
Okay,
I took
okay.
I've taken a year off. Me and my partner took a year off this year.
Oh, gotcha.
And
All right.
had a gap year. So I guess the 30-second story is, yes, I went to uni with Hash. We went to Monash Uni. And then I did internship and straight into BPT afterwards. Did all my internship in BPT at Monash Health in Melbourne. And then got into oncology training, and I've done my oncology training at Cabrini, Eastern Health, and Warrnambool so far. And I've got 1 year left of my training, which next year I'm at the Austin. I'm doing a genitourinary and CNS cancer clinical trials fellowship.
Wow.
And as I was saying, super exciting. And as I was saying, yeah, me and my partner took this year off to travel and, renovate our house, do a couple of other interesting things.
Oh, sounds good.
So let's wind back. Let's think about med school, because I'm pretty sure you wanted to you knew you wanted to be a physician in medical school and you had no interest in surgery. If you had a med student who was like on the fence between pursuing BPT or something surgical, what are the things that made you go, oh no, I'm definitely going to be a physician. I have no interest in surgery?
Well, it's a bit harder when you're on the fence. I think for me, at least in med school, and I think for most people, it's a lot easier to say the things you don't want to do than the things you do want to do. And then eventually you just kind of eliminate enough things that you end up in the thing you end up doing. And I think the reasons, looking back, the reasons I would say still choose to do physicians probably wouldn't have been the reasons I chose then. So I think
what were they then?
I think then it was just purely that, you know, physicians was what interested me. I liked, you know, the medicine of it. I liked the diagnostics. I liked, you know, the mind stuff, the communication stuff more than, you know, a procedural element. And, you know, there's some of the other things which I had already decided probably what went for me, you know, things like psychiatry or, you know, ONG and some of those other stuff, which are in their own little side paths. And
Okay.
yeah, so I thought I'd give physicians a go because of that. But I think going back, that'd still be a big part of what would push me to make the same decision. But I think probably, and you know, somebody who went down the surgical pathway, you can correct me if I'm wrong, Hash, but I think most of us don't think at the, you know, med school level anything about any of the pragmatics of any of the pathways. You know,
Yeah.
things like,
Mm.
you know, how many hours of my, you know, 20s and 30s am I going to spend, you know, late nights working and studying for this exam and that exam, or, you know, all the stress and turmoil of getting onto a program, and, you know, how old am I going to be by the time I'm a consultant? You know, what's the lifestyle going to be as a consultant? What are the job prospects afterwards as a consultant, and things like that.
Mm.
Well,
And
this is exactly the point. Like, we didn't think about any of these things, but
yeah,
nowadays, way more med students are acutely aware of those aspects. I don't know why that change came about or how that change came about, but there's definitely bigger focus on those questions that you just said.
I don't
Yeah,
think
go
I
on.
thought about those things that much,
No,
but
me neither. No,
Yeah,
I
same.
mean,
not as much. Not in terms of like, what is it going to be like when you're 55 and on call? No, didn't really think about that in med school. Okay, so you said that those were the motivations in med school. Nowadays, in terms of now, what would you say your motivations would be for being a physician?
yeah. So I think the stuff that I would have thought about in med school still applies. You know, I still find the medicine interesting, and all the above still applies. Especially, I reckon with oncology, there's a lot of really interesting science behind everything. You know, there's a lot of pathways and molecular stuff and all of that that's developing that makes it really interesting, and you get to see how those, you know, those theoretical things actually come to life as such when you know, all these new drugs come out that target, you know, XY gene with XY mab that we've never heard of. And then I guess there's other things. I mean, for me, probably the biggest thing would be the patient relationship, because, you know, a lot, like, and this applies, I guess, like, across a lot of specialties, but especially I feel like with onc, you know, because it's not a happy moment for anyone. So everybody's, you know, everyone's stressed, family stressed. It's probably the, you know, it's the worst moment in anybody's life when they're coming to see you. So there's guiding them through that, and, you know, just doing the same medical actions as anyone else, but communicating it in a particular way, or, you know, comforting people and things like that is really rewarding, and you get to build a really strong relationship with your patient. And that's probably the most rewarding thing for me. And, you know, a lot of the other stuff comes and goes and becomes, you know, say interesting at times, boring at other times, but that's one thing which sort of stays and kind of always keeps pulling you back. And I mean, Hash, you would have probably seen a fair bit of that as well when you were like ENT regging and things, that when you have these people diagnosed with these big nasty head and neck cancers and stuff, and you get them through a big difficult operation, it's pretty rewarding.
Yeah, definitely. So you like 6-hour ward rounds?
My ward rounds never go 6 hours.
Oh,
You haven't been on one of my ward rounds.
No, I haven't. I don't intend to.
Yeah.
Can I just
okay.
sorry? Can I just say? I think one of the comments was saying, I was saying mate too much or something. I was like, they're gonna create a mate counter or something.
You had a mate counter.
Yeah.
So now he's on high alert.
AJ, can I just ask though? When did you apply for a BPT training?
So I applied for an internship for BPT.
Oh, you
training.
did? Right. So
Yeah.
you kind of
Would you recommend that? Like, or would you say, oh, maybe you should do, get a little bit more experience before you do BPT? Or would you say applying an internship is the way to go?
I reckon. I mean, it depends on how sure you are with things. Because if you if you need if you need if you need a rotation, which isn't a BPT rotation, to figure out what you're going to do with your life, or to keep your options open, say you're pretty on the fence about GP and BPT, and maybe you're still you're strongly leaning to GP, and you want to do a general year so you can get your peds rotation for your GP or something, do that. But if you think there's a pretty reasonably high chance that you'll do BPT, I'd just apply, because at best case you start doing it, you decide you love it, and good, you've saved yourself a year. And worst case, you just get good experience in internal medicine rotations, and you decide it's not for you after BPT1 and you do something else. Because, I mean, you don't really do any study or anything else extra in BPT1, and the rotation's a good experience regardless. I mean, yeah, if you need the time to figure out what to do and you just have no clue what to do, then the general year might give you a bit more broad experience. But the way the applications for, each year work is that you only get like a couple rotations of any year before you have to decide what you're going to do the next year anyway.
Great segue. How did you prepare your application? I mean, you'd done a paper in cardiology in med school, and like, what should someone be doing if they decided, yep, they want to do BPT? How do you prepare your application? How do you do your resume, etc.?
Yeah, so I'd done a couple things. The two things I had done was, I spoke to the people at my hospital. So I think that's a good idea. If you're an intern and you want to do BPT, introduce yourself to the people who run the BPT program, find out about it. They often have an info night or something, or if not, just reach out to them and say you're interested and, want to chat, or even otherwise, just to let them know you're interested. I think that's important as a first thing. And if you're on a medical rotation, make sure your registrar and consultant know that that's what you're interested in, because more often than not, if you're a good dedicated intern, not saying that this is what happened to me, but and you tell your consultant that you're interested, then everybody knows everyone. You would be surprised if they put in a good word for you. And I think that's probably part of it as well, is just getting a good reference, doing your best work. Every rotation as you should anyway. And then, as Hash said, stuff like research and stuff helps. I don't think in any way anybody should have the expectation that you have to have publications, or, that you have to have something done by the time you apply to BPT. I don't think that's in any way a standard.
So you can be a competitive BPT applicant without having any publications?
Yeah, I definitely think so. I don't think that there's it's been obviously a few years since I was applying for BPT, 6 or so. But even now, I wouldn't think that would be the expectation. I'm sure it helps, but I wouldn't think that you need one.
And I was just going to ask AJ, so in terms of applying for a BPT, I guess more specifically in Victoria, because you guys in Victoria, is it state-based or is it hospital-based? Like, just applying for a BPT in the first place, how does that work? Yeah,
it's all state-based for us. At least it was when I went through it. I'm pretty sure it still is. So the way it worked was basically that you had to do a few individual applications for things to work, but basically you mainly just put in this, one app centrally. And
so it's a match.
Yeah, it's a match. It's a match. But I think nowadays, I'm not sure. I've heard that some of the hospitals are offering internal applications for some candidates earlier. That's what I've heard, but I'm not sure about that. And then, and I think it's a bit variable as to hospitals that if they do interviews or not. It's been a few years since I did.
Okay. Um,
I do have one thing to add to that. I think, no matter what you choose to do, the one piece of advice I give whenever I've med students, and something I wish I'd probably done a bit earlier is, pick something that you're interested in and pretend like that's what you want to do. Because I think that it's really easy, like at least personally, I found to kind of fall into that trap of thinking to yourself, oh, I might want to do oncology, I might want to do gastroenterology, I might want to do this or that. And then you don't start, introducing yourself to anybody in that specialty or finding out more about that specialty or doing research in that specialty because you're not sure if that's the specialty for you. And then often by the time you figure that out and you're like, yeah, this is what I want to do, it's a bit later and a bit harder to get a jump start on those things. So, even if you're, finally a med student or something like that, and you think that you're probably leaning down the physician's route and, one of these three specialties are the things that sound interesting to you at the moment, pick one and try and get in touch with somebody, find out a bit more about it, maybe start getting involved in a bit of research. Like, it'll never hurt you to do that. At worst, you get some experience, you pick up some contacts, you learn a bit about a career, and you do a bit of research in something that you don't end up doing. But most of the time, if you have any, research in anything, that's giving you a foot ahead, and they don't really care that much what it's in when you're going to apply for, for specialty programs. There's some specific things where, they require it to be in your specialty, but most of the things, it just adds to your resume, and you get the knowledge and experience of doing that thing. So it's often better just to, even if you're working towards the wrong thing, work towards something than working towards nothing.
That's so true.
that's wise.
Yeah.
Did
Those
you
are wise
consider
words.
any other specialties?
Yeah, I guess at various stages, lots of different specialties. So, when we were in med school, I was still kind of considering surgery a little bit. And, when me and Hash's first rotation was together at, as colorectal interns at Dandenong, and we had a really good rotation, and the surgery register continually tried to convince us that surgery was the only path in life. And, I definitely was considering, would have considered GP as well if, I'd gotten into hospital and didn't enjoy the internal medicine stuff. And then within physicians, until probably like at least kind of late into my second year of BPT, I would have had other specialties on the cards. I was interested in cardiology or gastro for a little while, and every time you do a rotation and you enjoy it, you sort of think maybe you might do it.
I could see as a gastro.
Yeah.
Yeah. Now, what was I going to say? Somebody asked about tips on passing the clinical exam.
BPT exams, yeah.
I mean, passing the BPT exam, that's such a huge thing. You'd study for like 2 years. Give us 3 tips.
Okay, all right. Before I go into that, just because if there's any med students who aren't as familiar with like the structure of BPT and how the exams work, BPT 1, you basically just get some experience, get your feet, figure things out. At the start of BPT 2, usually people start studying for the written exam, and the written exam's this sort of 2-part exam, full of all these multiple choice questions that you then take at the start of BPT 3. If you pass the written exam, then in sort of the middle of BPT 3, about 4 months after the written exam, you take a clinical exam. And the clinical exam has 2 sections to it. There's a long case where they put you in a room with a patient, you talk to them, examine them around about an hour, and then, present all their complicated, 5 issues and what you're going to do to fix all their problems magically. And in the short case, they get you to examine a patient without talking to them and try and figure out what they have and grill you and question you about it and things like that. So it's a pretty long, arduous process. You spend a long time studying for it. And you sort of dedicate about 18 months of your life to it. And so like the number one piece of advice would be to have a good group. So everybody usually kind of gets together into study groups, and usually those study groups, you meet with kind of weekly or so, and prepare for the written exam together, and then you go through to your clinical exam, and often your study group will be the same group that you'll do practice with along others and things like that. So I think.
So would you guys allocate each other topics and then teach each other?
Yeah. So the way we did it was, we'd have 3-4 weeks that we were spending on cardiology, and we might, allocate each other certain past papers to go through, or there might be certain topics like this person's doing heart failure, this person's doing arrhythmias, etc. And you all get together and once a week and go through all those things. So you end up spending a ton of time with those people. So you want to pick, a good group that you're going to get on with. We're all going to be easygoing because everybody's going to be stressed, and it's always annoying and complicated to, have 5 people who are on different rosters find a time and place that they can meet, and where there's a good chance someone's going to miss out on some of them. And people who you can like build a bond with, enjoy your time with, who will support you when it gets really tough and you're really over it and you just want to give up, and people who just make you feel a bit better. And so that, at least when you're dedicating your life to this exam and you barely get any time to, spend good social time with your friends and your family and stuff, that you get a good social outlet, at least with your group, even if you're just doing the damn study questions.
Shout
AJ,
out to study buddies.
Yeah, AJ, what's the pass rate on the BPT exam? Just roughly, I guess.
Yeah, I'd have to check. I think roughly, for the 2 exams overall, I think it's something like 2/3 or something. But someone might correct me if I'm wrong.
Yeah, so it's definitely not an easy exam. Obviously, you spend ages preparing for it. And is there like a maximum number of attempts that you can do, or can you just always if you fail?
I think it's 3 maximum attempts now.
Right.
Can we get a fact check? Someone fact check.
Yeah, that's what we need. Like the other podcasts have some like guy on the side to check on things and bring up.
We can't afford that right at the moment. Maybe later.
Yeah, it's fair enough.
This is free Zoom, AJ. Free Zoom. So brief from what I've observed, I think one of the questions is about competitiveness. From what I've observed, most people who set out to want to do BPT got into BPT somewhere. And then there's a small percentage who don't end up finishing BPT because they change their mind. That seems accurate, right, AJ?
Yeah.
Okay. And then you get onto your advanced training applications. What's that process like?
Yeah. So I guess so the way it works with the advanced training applications is you finish and pass your written exam. And then usually sort of in the time leading up to your clinical exam, although this might have changed because I heard they moved the clinical exams a bit earlier, you start applying to the specialties you want to. And the process is a little bit different for each of the physicians' advanced training specialties. But generally speaking, essentially all of them have some kind of centralized match process. So you apply to the one central thing. Some of them have pretty clear and open, criteria of how they score you and, what percentage of weight they apply to different things. But generally they, somehow grading and scoring your resume, your references, and your interview. And they all generally have some component of that. Usually the references, what they require kind of differ between different specialties. So oncology, for instance, has it was 2 consultants and ideally one NUM, one nurse unit manager, and the interviews are all a bit different.
But you said none.
None. You could try it, man. I don't know if it'd help your application. I heard it, but you could try it.
Some prayer.
It's probably harder to get. And and usually the interview is some kind of panel interview where, there's one representative from each of the hospitals in Melbourne, and you have this intimidating group of 10, 12 people standing and sitting in front of you, and they all ask, a series of different questions, and then afterwards they all decide on giving you a mark based on that.
Do you know the weighting of each component?
It depends. It's very variable between different specialties, I think, as to how much it is. Some of them place more weight on the interviews. Some of them place equal weighting on all of them. Some of them just don't tell us what they do.
Yep.
And I guess the competitiveness of applying to specialty training is different in each one, and sort of the way they work in terms of, some of them you just apply and that's it. Some of them they have a certain day where they expect you to go, meet with all the heads of units and introduce yourself, do a kind of speed dating kind of thing. And then other ones, people, it's just generally advised that you go and talk to all the heads of units in Victoria and put your name out there. And some of them you don't do any of that. You just apply to the central match and that's it.
So from what I've observed, cardiology and gastro, very competitive.
Yep.
And that's demonstrated by the fact that there are now unaccredited cardio and gastro registrar jobs. I've heard geriatrics is a more accessible specialty, and perhaps the rest are somewhere in the middle. Does that sound right?
Yeah, generally I think geriatrics, hematology sometimes, and general medicine are all fairly accessible. I guess the first thing is, not everybody comes out and gets some kind of job somewhere. Might not be an accredited job, and might not be an accredited job in your desired specialty the first year out, but everybody gets some kind of employment somewhere. And there's a lot of them that vary by year, because the number of training spots might differ, the number of people who are interested might differ. Like, so for oncology, for instance, it's usually somewhere in the middle, but it's of your 3 years of training, 2 years of core years, and 1 year is non-core. So core being an oncology registrar, and non-core being something like I'm doing next year, where you're doing a clinical trials fellowship, a non-core year. So, the number of spots available just depends on, how many people decide to do a third core year or not. So, 1 year, I think the year I did it, there was like 11, 12 like applicants or something, positions available, but other years there might be 20. It just varies. So it's a bit of a luck of the draw sometimes, and especially for smaller specialties like rheumatology and things like that, where there's only, a handful of training positions per year. It's quite variable on how many people are gunning for them and how many spots there are that year too, as to how difficult it is. But generally what you said is right. Gastro, cardio are hard. Neurology often can be a little bit hard, and rheum as well. And then a lot of the other ones are in the middle, or dependent on the year.
Not much room in room.
Worked on that one, didn't you?
Yeah.
AJ,
is there an core year?
Sorry, I was just going to ask: is there an exit exam for oncology at all, or once you get in, there's no exam afterwards? Yeah.
Thank God, no. The only exams you have to do are the BPT exams, those two. And then none of the physician specialties as of now have an exit exam. The exception to that being hematology. If you do lab heme, then you have to do the FR. What is it? The FR CPA exam, the pathology one.
Right. Okay.
I was going to ask, the non-core year, you can like genuinely do anything. You could do like a ID job or something.
There's requirements.
Is that right or wrong?
There's requirements as to what you have to do for the non-core years. You can't do anything at all, but it's pretty wide as to what you can do. I'm pretty sure you would be able to apply a alternative specialty as your non-core year. So, if people do like dual train with Gen Med, then a Gen Med year could be their non-core year, I'm pretty sure. and people do things like research years and PhD years and things like that, which can all apply as non-core years too.
So that's great segue, AJ. We have a friend who's doing dual training in Jerry's and GenMed. What's the point in that? What's the advantage?
Well, I guess there's a couple things. It can be that you're just genuinely interested in two things. You might be trying to, broaden your ability to do things other than just a subspecialty. You might be someone who just wants to, genuinely be an all-rounded physician and be able to do gen med and know those things. And some of them pair well together, but you really got to think, how much are you going to use each of those subspecialties when you actually graduate? Get your letters and things. Like, if you pair things with a good overlap that you can actually practice both in and stay up to date in both, then sure. But in some other things, as medicine gets more and more complicated and more subspecialized, it can be pretty tricky to stay on top of the breadth of your own specialty, let alone another one. So you just have to think about it pretty carefully. It's definitely can add a lot to to your repertoire for certain people and certain specialties. But you've got to think about what specialties you're going to do, and how much you're going to remember, how much you're going to stay clinically up to date and do well.
All right. So cool. You finished your BPT, you finished your advanced training, and now you're getting your letters. What do you do now? Like, you're about to be a free agent, independent, no more roster, no more medical workforce. How do you fill up your time? What do you do?
Private sector money.
Well, it's a tough question. I mean, it's not one I've done yet, so it's not one I'm going to have a huge amount of experience in. But generally speaking, I mean, you can either do further training. So, and I'm going to put a big bunch of things in further training. So, that might be doing, a master's in something, or PhD, or just a bunch of research, or a fellowship.
Because you can do fellowships, and yeah.
Depends on the specialty as to how much culture there is for different fellowships.
Is it expected in oncology, or you can
in
just
oncology? It's pretty routine. So most people will do at least kind of one fellow year, and it's not uncommon for people to do an overseas fellowship. And that's why you'll see this. There's lots of fellow opportunities, but domestically and overseas. Peter Mac has some like 8 to 12 or something fellows now, something like that.
Wow.
But if you look at other specialties, there's probably not as much of a culture for it, or not as many fellow jobs available. So it depends. But lots of people, it's pretty common for people to do PhDs, other things like that. And then in terms of work, right, you can have clinical work that can be public, that can be private. And then there's also other stuff outside of that people do, like education stuff, jobs with, the teaching departments of the hospitals or the universities and things like that, where they teach all these med students and all the things they need to learn. And then you can have people do other stuff in private sector and stuff too, working for pharma companies or research and all this other stuff too. That's probably a minority, but there's other opportunities.
Big pharma too. Big pharma.
And just to add on to that, how competitive is to get a public position, like like a big city in Melbourne or Sydney or even Brisbane, things like that as well, as an oncologist?
Oncology wise, at least pretty competitive, like really competitive. I can only speak to Victoria, but I suspect New South Wales is pretty similar.
Pretty similar,
and it's might be a bit different in some of the other states. But generally speaking, very competitive to get a metropolitan public appointment, and some of the more academic centres probably want people to be doing a PhD to have an appointment there. But it depends. A lot of it's setting yourself up well to start, and sometimes, being in the right place, right time, from what I hear from people. But, I'll probably get to the sticky end of that, and, in the podcast season 3 or 4, I'll tell you if it worked out or not.
It'll be season 3 with how slow we go.
Yeah.
All right. Let's do some
know.
quick fire questions from the Reddit.
Listeners?
Are there any procedural aspects, yes or no?
As a registrar, yeah, probably. Less and
Like
less
what?
so. So when I was, fairly reasonably commonly, people do acidic taps and lumbar punctures. And then, I did pleural taps and things when I was regionally working as an onc reg, but not too much. And you're probably pretty unlikely to routinely keep up those skills to do those things as a consultant, unless you're working in a regional center.
From what you've observed, is there much opportunity in the private world?
Not too much. So in private, it's back in the day.
I don't mean in procedures.
You mean procedures, just in general?
No, in general.
Yeah, generally, there's a fair bit of opportunity privately. It's a bit of a different world and a kind of different kettle of fish to get going in there. But there's definitely lot of oncologists do private work and mix that with their public, or some do purely private. And there's a reasonable amount of opportunity, especially, I think, a bit further from as well.
The future of oncology, what's it look like?
I think it's really exciting. I'm clearly biased, but I don't think any other specialty is developing as fast as oncology. Every year, there'll be a handful at least of new treatments approved and put on PBS for us to use, new developing research that's making material impacts on patients' lives every single year, and conditions and the grimness of everything is slowly but surely marching forward and making a meaningful difference. So there's a big opportunity to learn and continue learning of your career, because things continue changing. And there's a big opportunity to contribute to all of that research with it, whether that be, we're just working in trials, or even just referring patients to trials, and doing more dedicated research work or primary research work, lab work, and things like that too.
I think that actually covers most of the listeners' questions, like just broadly. I think we've covered most of it. Any of the other listeners?
Well, while he's looking at that, one thing I was mentioning to Hash that we sort of touched on a bit, but I think is probably if you're aiming towards advice for med students and things, one thing which is really hard, but both of us I think would probably have liked to do more as a med student is think really hard about what the years ahead of you getting to a certain specialty are, and what the life as a consultant is going to be, how much weight you're going to put on those next few years and those further years of your life, and how much you're willing to give up in both phases. And I think that even if you do that, chances are who you are and what you want will change, and everybody you get into relationships and your priorities might change, and it's really difficult to make the right choice. But I think it's still important to just think about those things and openly, like talk to your friends or talk to your family or partner about those things, and just make sure that if you don't know what the commitment's going to be, what the hurdles are going to be at the start, or what the life's going to be at the end, try and talk to the registrars, or if you're comfortable, some of the consultants in that specialty. I think people are more open to sitting down and giving advice and talking to these things than people expect. And I think even if you don't know the answers, and I don't think anybody will know the answer 100% and make the right decision, thinking about it and talking about it's pretty helpful to consider those things. Would you agree, Hash?
Yeah, 100%. On that note, I remembered a question I wanted to say. On call, what's on call like as a oncology boss?
Good question. Yeah.
As an oncology boss, not too bad, probably. Thinking when I'm on call, I have pretty rarely woken up my bosses overnight. And, usually they'll get a call or two if I've got a really sick patient, or even just text messages. And even as a registrar, it depends on the center, but generally not too bad as specialties go. There's not many things that would ever really have to come in to hospital physically for. I think I've only come in on call once ever. And, you get probably middle of the ground in terms of different specialties, in terms of the number of calls you get. So it's not terribly bad. If you're on call a bunch in a busy place, you'll get pretty tired, but in your average center, it's not too bad.
Cool.
Awesome. Great.
The last thing I wanted to say was, I think there was recently in JAMA Open, there was this paper that was published that looked at physician burnout as a ratio of physician burnout to fulfillment. Now, I didn't actually read the paper. I just looked at the little plot because it looked very interesting.
And that tells you everything you need to know about Hashem.
And that tells me everything. That tells me everything. Just skim straight through it. Straight to the pictures. It's a picture book to me.
Yeah. I was surprised that you were gonna read JAMA in your spare time.
No, not quite. But it's a cool concept about versus fulfillment, and it had 4 quadrants basically: low burnout, high fulfillment; low burnout, low fulfillment; high burnout, low fulfillment; high burnout, high fulfillment. Where do you think oncology sits, AJ, in your experience? How, when you observe your colleagues and your seniors, how fulfilled to burnt out possibly do you think they are? Not necessarily. Maybe burnout's not the right word. Maybe it's like, I don't know, percentage of effort or something. I'm not sure what the right expression is.
Yeah. I mean, I feel like the fulfillment's pretty high. Like I think most people enjoy what they do. Most people I've met enjoy what they do. And the work's probably, the effort or the stress or the burnout, probably somewhere in the middle ground, I think. So overall, it's reasonably good, but I mean, it's pretty hard to judge those things. I think you sort of, at least me, I find it like the easiest thing is just to pick onto the material thing of, do I want to do whatever I see these people doing day in, day out, and these are the steps that I'll have to do and the things I'll need to do to get to it, and what my life will be like after that. Am I okay with that?
It's been great, AJ, and thanks for coming in for this podcast. Where can people find you? Where can people stalk you if they wish to?
AJ's address is... No, I'm joking.
Do you have an Insta, Facebook, or whatever? If you wanna, or we can put it at the end if he wishes. But, yeah.
none of which are public, but I'm happy for people to email me. I can pass on my email.
Yes.
If there's a student who's interested or has a question, I don't mind if they shoot me an email.
Amazing. Thanks for coming
you, everyone.
in.
Good job.
Thanks, guys.
No worries.
Well,
thanks for having me. Even if I had to,
everyone.
sit down and speak to Hash for all this time, I still enjoyed it.
All right, guys. All good, guys.
See ya.
Thanks for coming in. See you later.
See ya.